Great. Good morning, everybody. Thank you for joining us again for our Monty Hart Weekly Cath Conference. And this week, we really have a good friend of mine, and Edwin Ho will be joining me in a moment, Neil Pham. Neil's from Toronto and really has become a leading expert worldwide in mitral and tricuspid intervention. He's doing novel devices. Half the devices Neil does, I only hear about weeks or months later. So he really is an expert in really pushing the field and pushing innovation in this field. And so I think we'll all learn a lot from his experience with tricuspid valve interventions. So, Neil, thank you for joining us.
Thank you for the kind invitation. I'm going to share my screen. Can you see the slides?
Yes, we can. That's great. Perfect.
Okay. Great. So I'm going to talk to you about transcatheter tricuspid valve intervention, patient and device selection, and hopefully we can make this interactive and have some time for questions. So disclosures. So the forgotten valve, no longer forgotten, tricuspid valve, not exactly tricuspid, often has 4 and 5 leaflets, as we'll discuss. As we know, TR is predominantly functional due to left-sided valve disease or LV dysfunction, pulmonary hypertension, atrial fibrillation. But there are an important number of primary causes of TR which are increasingly recognized, such as tricuspid valve prolapse and lead-induced TR. So we know that TR is bad for you, and severe TR clearly has an impact on survival independent of other prognostic factors. So the etiology of TR, as we're discussing, is mainly due to left-sided valve disease, LV dysfunction, pulmonary hypertension. This concept of isolated or atriogenic AFib-related TR is an important etiology. And on the panel on the right, you see the outcome with respect to death, heart failure, and development of AFib varies quite considerably based on the underlying etiology. So we continue to learn about tricuspid anatomy. This recent paper highlights the great variability there is in the morphology of the tricuspid valve, and often this valve has multiple scallops of the anterior, the septal, and the posterior leaflet, leading to sometimes 5 or 6 leaflets. This is particularly relevant when you're considering edge-to-edge procedure where leaflet grasping and choosing the right leaflet pairs to join together becomes quite critical. And perhaps it's less important for other devices such as annuloplasty and valve replacement. So the clinical assessment of tricuspid regurgitation patients is extremely important. We continue to hone this. This comes from the PCI tricuspid focus group. The ideal patient has no left-sided heart failure, normal RV function, no pulmonary hypertension, no lung disease. Their kidneys and liver still work fine, and they're not frail. Now, on the other end of the spectrum, patients who have biventricular heart failure, recurrent hospitalizations, precapillary pulmonary hypertension, lung disease, cardiorenal, cardiohepatic syndrome, and frailty, these represent patients that are probably too far gone and are best avoided. So the hemodynamic assessment of patients who have TR is very important. Certainly most labs are doing invasive right heart caths to work these patients up. And here's some data that was published earlier this year, just highlighting that invasively measured PA pressure predicts survival. And certainly patients who have precapillary pulmonary hypertension, as shown in panel B in the black curve, have the worst prognosis after intervention, whereas those who have post-capillary pulmonary hypertension, otherwise known as group 2 pulmonary hypertension, can do quite well, almost the same as those who don't have pulmonary hypertension. So if we look at surgical guidelines for TR, they're very conservative. There are no class 1 indications for isolated tricuspid valve surgery. Really just at the time of left-sided valve surgery is a class 1 indication. And part of the reason for this is that tricuspid surgery has significant early and late mortality and significant morbidity, such that any given center is probably doing only 5 or less isolated tricuspid surgeries per year. So as a result, until recently, TR has been grossly undertreated. Less than 5% of patients in the US would be offered surgery. And so there is this unmet need. So here is a snapshot of the current tricuspid valve device landscape, which continues to evolve. This all started with leaflet approximation, and the tricuspid clip has now been iterated to be a dedicated device called the TriClip. We have a competing device for TEER called the Pascal. And we have annuloplasty devices as shown on the right. And then on the top left, emerging valve replacement devices, both heterotopic and orthotopic, which we will discuss. So we are developing a toolbox for the tricuspid valve, just like for the mitral. So we've learned a lot about tricuspid intervention from this TriValve registry, which was a compassionate use experience from a number of centers around the world. And really, in the initial experience, you can see that 2/3 of the cases were off-label application of the mitral clip for edge-to-edge repair of the tricuspid valve, with a smattering of other devices as shown here. Now, when we do edge-to-edge, the goal is to improve coaptation by joining the anterior leaflet to the septal leaflet and or to posterior to septal leaflet. And this will improve coaptation and as well affect a modest indirect annuloplasty effect. So we'll share a case, a typical patient that we would treat, 89-year-old gentleman with previous TAVI and pacemaker. He has both severe MR due to P2 flail and severe TR and heart failure. So the approach we take at St. Michael's is to do combined intervention in such patients, particularly when they're elderly. And so focusing on the tricuspid valve, this is the one of the most important echo views. It's the short axis transgastric view. And as you can see, even before we put color Doppler, there's a significant coaptation gap in the middle of the valve. When you look at the color, you can see there's an eccentric jet. And the reason for this, the patient has a septal leaflet prolapse with a focal flail, as shown here. This was actually not thought to be iatrogenic. This was primary TR with superimposed anodilation leading to secondary TR as well. So after successfully treating the mitral valve, we approached the tricuspid valve. Our default clip, whenever possible now, is the XTW, which we can discuss in more detail. So the first target is anteroseptal, and there's the first clip deployed. You can see a tissue bridge there, anteroseptal commissure, residual TR in the center of the valve. And so there's a target to place a second clip posterseptal, so another XTW. As you will all appreciate, imaging of these procedures is critical. And if you don't have good imaging, you really can't be sure you have a good leaflet grasp, and half the procedure is confirming leaflet insertion. So here's after the second clip is deployed. We've got a nice reduction down to mild and excellent tissue bridge in the transgastric. This patient did extremely well. You can note up here, there's pacemaker lead bouncing around in the posterseptal commissure, but this had nothing to do with the mechanism of TR. So with respect to data, we have analyses like this, which was a propensity matched analysis from a TriValve matched to patients who were treated medically. Majority of these patients had undergone edge-to-edge repair. And in this analysis, there appeared to be improved survival free of heart failure and overall survival in favor of tricuspid intervention. So this foreshadows the randomized trials, which we'll discuss, and many of which are underway. So with respect to prospective data, we have the Triluminate feasibility study. This was 85 patients, quite a typical snapshot of the demographics of the patients we treat. majority female with a lot of AFib and previous left-sided valve intervention, a few patients with leads, many who have renal disease. They have dilated right ventricles with mild dysfunction, highly symptomatic, preserved LV function, modest pulmonary hypertension. And so in this cohort, which was the TriClip NT first generation device, patients got to moderate or less TR, which is the definition of procedural success, 70% of the time. Now, in contrast, on the mitral valve, we can get that 97% of the time or so, but it continues to improve with respect to edge to edge for TR. Now, this TR reduction was associated with significant symptomatic improvement and improvements in quality of life. And there was the signal towards reduced hospitalizations in the intervention, post-intervention compared to the year pre, and the signal that procedural success, reducing the patient to moderate TR or less, was associated with less heart failure and improved survival. So again, another suggestion that reducing TR leads to improved outcome. So what we need are obviously randomized trials. The first one that started is the Triluminate study. This is 450 patients. It's an international trial. And this is being randomized against guideline-directed medical therapy, which is essentially diuretics. The primary endpoint is a composite of mortality, tricuspid valve surgery, heart failure hospitalizations, and quality of life. And there's also a single-arm component of the trial. So inclusion, patients had to be treated with diuretics for at least a month. These patients all get right heart caths to confirm their PA pressures are not too elevated and that they're optimized prior to being enrolled. And exclusions, PA pressure more than 70, precapillary pulmonary hypertension, uncontrolled systemic hypertension, severe LV dysfunction, etc. So the trial has been enrolling very well. It's about 2/3 completed, and will provide the first glimpse as to whether transcatheter intervention improves clinical outcomes. So we've seen this evolution of the MitraClip. There are now 4 versions of the clip, allowing you to tailor the treatment to the individual patient. And as we've discussed, the TriClip system is really a dedicated delivery system. For the tricuspid valve, the clip on the end is the same. Now, there is a second device for TR called the Pascal, which is designed to treat large coaptation gaps, has a central spacer, and was the first device to offer independent leaflet grasping, which I think is a game changer for treatment of TR using TR. So we had the opportunity to do the first in-man case several years ago. This is truly compassionate 82-year-old woman with recurrent heart failure, RV failure requiring milrinone, weaned off milrinone, not doing well, and has hepatic or renal failure and ascites. So, but interestingly, not frail. So here's the echo showing torrential TR, and the 3D echo showing the coaptation gap in the middle of the valve. So the procedural strategy was to place 2 Pascal devices with a percutaneous clover technique, the first anteroseptal as shown here, and the second postseptal. So this is post-implantation of 2 devices. And we had a very nice reduction in TR down to mild. Gradient was 2, and this patient did extremely well. Was discharged from hospital and had no further heart failure subsequently. So we published the initial compassionate use experience a couple of years ago, and the initial results look quite favorable with respect to TR reduction, symptom response, and functional capacity. So the Pascal device is also in a pivotal randomized trial against medical therapy called the CLASP II TR trial, and there are a number of sites enrolling in the study. Now, what about patients who've got mitral regurgitation, you have a successful mitral clip, but they have persistent severe TR. These patients do quite poorly if you leave the TR alone. So patients who have severe residual TR have quite a poor prognosis. What do we know about the TR getting better after treating the MR? It's probably only 25% or so who will see TR reduction after treating the mitral valve. The main predictor of this happening is the PA pressure comes down. Certainly patients in atrial fibrillation are more likely to have their TR persist because they also have annular So with respect to evidence for combined mitral and tricuspid TR at the same sitting, this is just registry data, but there is a signal towards better symptom response and less heart failure hospitalization in the patients who have combined intervention versus just isolated mitral intervention. And this analysis, comparing patients from the TriValve registry and from the TRAMI registry who just had isolated mitral intervention, suggests improvement in mortality in favor of combined intervention. Now, data that's come from our group that's in press also compared the results with medical therapy, combined intervention, and then combined valve surgery. And here, there's the suggestion that there's less heart failure hospitalizations and trend towards less mortality with intervention or surgery compared to medical therapy. So really, this begs a randomized trial so we can learn more about this. There are pros and cons to combined versus staged procedures. In favor of this, it would replicate the surgical standard. It is generally efficacious and safe. You avoid a second GA in an elderly patient. At the present time, the cost is less, and there is the signal towards less heart failure and mortality. In favor of staged procedures, sometimes the TR gets better after treating the mitral valve. If you have an unsuccessful tricuspid procedure with edge-to-edge, you may exclude other options, and these can sometimes be long procedures. And I suppose in the US, we also have to mention reimbursement. So here's another case, a 75-year-old gentleman who has severe right heart failure, ongoing symptoms, TR, mild artery dysfunction, PA pressure is okay, coronary disease, AFib. So his transgastric view on his echo shows a TR going into all three commissures and a coaptation gap up to 15 millimeters. So this patient had all of the predictors for failed edge-to-edge because the jet is not just anteroseptal or central. The EROA is torrential. He has leaflet tethering, and the coaptation gap is large. So we understand from the surgeons that there are limitations to tricuspid repair, mainly TR recurrence at follow-up. And so there's a need for tricuspid valve replacement. Now, the first generation transcatheter replacement device was the Navigate, was available in a number of sizes up to 52 millimeters, but had a fairly rudimentary delivery system such that the majority of these procedures were done via a surgical transatrial approach, beating heart. There were also a few transjugular cases. So in this initial compassionate use experience, this device was extremely effective at reducing TR. And in the patients who survived, had a very good symptom response. But when we look at the clinical outcomes, mortality at 30 days was up to 13%, with some need for surgical conversion. And so this starts to look a bit like the results of tricuspid surgery. However, none of these patients would ever have been offered tricuspid surgery. And so probably these results, at least for an initial experience, are quite favorable. But clearly there was a need for something that was truly percutaneous and transfemoral. And so the EVOQUE system, which was initially developed for the mitral valve, was subsequently applied to the tricuspid valve. And that patient that I just presented was the first in man that we did a couple of years ago. So this valve has ventricular anchors and then a self-expanding annular stent with a valve inside. The valve is designed with a valve-in-valve option, such that down the line you can put in a Sapien 29 if there is a valve failure. So a lot of planning goes into these procedures. Unlike for TEER, the replacement devices are really all about CT analysis in addition to echo. And so here's the delivery system with a 3D CT spin, just showing you the ability of the device to have both primary and secondary flexion so that you can get away from the septum. So here's the thoracoscopy. You can see this is 28 French valve. There's a safari wire in the RV apex. The ventricular anchors are exposed, and then you're grasping the leaflets similarly to edge. The guidance of these procedures is very intense and relies heavily on 3D MPR. So the imager plays a key role in these procedures. You want to make sure that you have leaflet capture on most of the anchors. Of course, some of these anchors can go into the commissure, and that's not a problem, but you don't want to have multiple contiguous anchors uncovered by leaflet tissue. So the first procedure went quite well. Here's the valve deployed. Procedure time was less than 2 hours, and the response was quite gratifying. He had to just trace PVL in the anteroseptal commissure, and obviously it went well because everyone's smiling at the end of the procedure, and you'll recognize Edwin Ho there on the left, and John Webb hiding in the back. So this patient's now had 2 years of follow-up. Valve function remains excellent. He continues to do well. And so I think, you know, tricuspid replacement has a bright future, but its role really remains to be determined. So the initial compassionate use experience of 25 patients was excellent. There was a 0% mortality, and importantly, there was 8% chance of needing a pacemaker, procedural success 92%, and almost all patients had essentially 0 or 1+ TR at follow-up. So this device has now moved into a pivotal trial as well. So the TRISCEND 2 is a randomized trial of EVOQUE TTVR versus medical therapy. So now we have randomized trials looking at edge-to-edge and looking at replacement in comparison to medical therapy, which is quite exciting. So here's another case, 63-year-old gentleman, ongoing symptoms, torrential TR, RV dysfunction, mild pulmonary hypertension, previous CABG, and he developed insidious onset of cardiac cirrhosis. He was referred to us from another cardiac surgeon who felt a redo surgery would be prohibitive given the liver disease. And his tricuspid annulus measured 55 millimeters. Now, the largest available EVOQUE or Navigate is 52. Here is the TE showing he's got quite a large coaptation gap, about 15 millimeters with leaflet tethering, which would preclude edge-to-edge. And so what to do with this patient? He's only 63. So the CT scan shows that his annular dimension is 55, and he was deemed suitable for another TTVR called the cardiovalve. So the cardiovalve is another TTVR that was originally developed for the mitral valve and is now being applied for the tricuspid valve. We had the opportunity to use this device several months ago. As you can see, they are ventricular anchors which are open. There's a bit of a difference here with this device because there are multiple points of fixation. There are the ventricular anchors which grasp the leaflets. There's a self-expanding stent with a valve in the middle. And then there's also an atrial flange which will provide seal from above. And so grasp the leaflets, and then deploy the atrial flange and deliver the valve as shown here. So the procedure went very smoothly. It's quite a fast procedure. As you'd expect, it completely abolishes the TR. There was no PVL, no heart block. And we got some pretty 3D echo images, again, showing no PVL. So what do we know from surgery? There have been a number of meta-analyses done comparing surgical repair with mainly annuloplasty to replacement. And although these are not randomized patients, this is all registry analyses with inherent biases. There is this signal towards less early and late mortality in favor of surgical tricuspid repair. There's also the observation of less kidney failure and less pacemakers with repair, which is already what we're seeing in the transcatheter space. The pacemaker rate after a transcatheter valve is somewhere around 10%. So the beauty of TTVR repair, little r, is that it's safe, but it's not always effective. If we look at the outcomes from these prospective studies, mortality is very low. The complication rate is similarly low, but the TR reduction is quite variable. And anyone who's done these procedures knows that sometimes you take the patient from torrential to severe, and they may have some symptom benefit, but we know in the long run that residual severe TR is not good for you. So tricuspid replacement is effective, but you must watch out for complications such as afterload mismatch, low cardiac output, heart block, as we mentioned, valve canting and PVL, embolism, and thrombosis. The current limitation of the replacement devices, many of these patients that we encounter have very large dilated annuli, up to 70 millimeters, and the current devices can treat only up to 55. There is the issue of the IVC to tricuspid annulus angle and the offset, which may affect the device trajectory. There's the need for lifelong anticoagulation. There's the open question of durability of a bioprosthesis and the theoretical risk of endocarditis, particularly if you're jailing pacemaker leads. So with respect to patient selection, repair versus replacement, I really view this as overlapping Venn diagrams. The population in the center is probably the majority of the patients with TR who have symptoms of right heart failure, preserved RV function. They have a coaptation gap less than 7 millimeters. They have excellent imaging of no pulmonary hypertension. It's an open question. Should we repair or replace this valve? I think it has a lot to do with their comorbidities and expected survival. In favor of repair would be small coaptation gaps, mild tethering. Patients with RV dysfunction will tolerate a tricuspid repair better than a replacement. And those who have contraindications to anticoagulation might be better off with a repair. And on the left, we have replacement, which is best for those who have large coaptation gaps, severe tethering, and importantly, lead-induced TR, which is really quite common. So in summary, a transcatheter tricuspid intervention meets an unmet need for patients with right heart failure to improve symptoms, reduce heart failure, and perhaps mortality. Improve case selection and device innovation with better technique continues to improve the clinical outcomes. And we have a number of pivotal trials comparing medical therapy with intervention. We'll have eventually, I'm assuming, trials comparing repair and replacement. So stay tuned. I think the future is quite bright for our patients with TR. And happy to take questions.
Hey, Neil. Thank you. That was awesome. Really fantastic presentation. As you can see, just because it's you, we brought like a whole serious panel here of experts to drill you on your questions.
Okay, good. Let's go.
No, but anyway, since we last saw each other this morning, Edwin's joined us, and there's no need to introduce Edwin. I saw him in one of your photographs, so the first in man evoked case. He was looking a little bit more relaxed then than he is now.
Maybe so.
More rested than I think now he's a little bit more stressed in New York. Overworked. And obviously Juan's with us too. So I'm gonna let them start, and we're gonna have some of the fellows join too.
Great.
Go ahead.
Great, thanks, Neil. That was a great overview, of course, of the entire landscape. One of the things that stood out to us was, when you were talking about TriClip tier, and you mentioned that your workhorse is now the XTW. I remember when XTR came out, and it was such a game changer for us. Do you find that the wider clip is giving you, really that much additional benefit? And then how do you choose between when, the narrower XT or the wider XTW is appropriate?
Yeah, so I mean, we published on the difference between XT and NT, and I was an early proponent of XT, as were many in Europe. It just leads to better TR reduction, but of course the XT can be a weapon in the tricuspid valve, very thin leaflets or severe tethering. So I do find that the XTW distributes the forces, leads to a more robust tissue bridge, and I think anecdotally there's less SLDA with a W. So whenever possible, we're using a W. Now, I do find that sometimes it's too wide to get between the cords and grasp the free edge of the leaflet. And so if it's clear that the leaflet's folding and not going into the center of the clip, then we will switch to an XT.
Yeah, I mean, wasn't that the same reason that Edwards now in Europe are recommending for all their commercial cases to use ACE rather than Pascal? Is the fact that sometimes you just can't get between the cords with the Pascal, and with ACE you can. And so you end up curling, particularly the septal leaflet, rather than getting underneath it.
100%. Pascal
Yeah.
ACE is much easier to use than Pascal in the tricuspid valve, for the average anatomy.
Right. So maybe we need to start trying, because we've been kind of stuck on XTs, using mostly XTs for our tricuspids. But maybe we need to start using XTW, because now you're the second person who said to us that, XTW, you're using XTW as your default. We were just reluctant because of concerns that we wouldn't get between the cords, and so we would, pull down the leaflets. Okay. One.
Look, I mean, at the present time, Neil, by the way, phenomenal talk. And I really think that, you were very clear in your concepts, which is actually difficult in a field that is actually brand new. And one of the things that I'm always scratching my head is about future device selection, like your closing slide about repair and replacement. Because, from one side, you have the beauty of getting rid of completely TR, but actually you pay the price on anticoagulation and potential complications related with a permanent implant. But one of the things that I wanted to ask you is about interaction with the RV. For some reason, it seems to be more prominent, the issues than actually on the left side. And this is actually something that we just started to learn, and there's a lot of work going on, and wanted to get your opinion about the interaction of the implantable component with the RV, pulmonary hypertension, and our ventricular dysfunction, and how important that is, and how can you screen patients, out for a device that can potentially interfere with the RV function.
I think it's a critical point, Juan. So, from the beginning, we've done right heart caths on all these tricuspid patients just to try and understand their physiology better. And certainly before replacement, you need to be sure that they don't have high pulmonary vascular resistance, that the RV function is not, too down, and the PA pressure is not too high. Because if it is, and if they have precapillary pulmonary hypertension, the RV is at great risk of failing after the procedure. And, afterload mismatch is something we see It's usually transient, goes away after a few days of support with inotropes. But if you choose the wrong patient, in theory, they could have a permanent low output state and pass away. So we don't see this after edge-to-edge or annuloplasty because we don't get rid of the TR completely. Now, the other point you made is the ventricular footprint of these devices is quite different. And some of them are occupying a lot of space in the RV. And you put one of these huge valves in a little old lady's RV, it's contracting against the valve. They do feel better, but I wonder what that does in the long run.
I must admit, one of the things we've seen now in all our tricuspid valves is for a few days, patients have an extreme amount of activity, okay, ventricular activity, and that they never had before. So far, we've not seen any negative consequences, but literally that activity comes from that ventricle, just like really pushing down, on this tight valve. And the other thing we've noticed, because they're all in a clinical study, is we've noticed a troponin rise in almost all these patients. Okay, no ECG changes. I don't think it's a coronary issue. I think it's actually coming from myocardium and the myocardium interacting with the anchors and this large valve. But every single patient so far has had a troponin rise. Yeah, which is interesting. I don't think we're appreciating this on the mitral side as much. Right. Neil, we've got a number of structural fellows visiting and clinical and research, and I'm going to pass you on to them. I'm sure they have tons of questions. Who wants to go first? Andrea?
Yes. Good morning, Dr. Farm. I really liked one of your final slides on patient selection. It was meant on excluding patients based on some criteria. I wanted to ask you the opposite. For a patient who has both candidacy to repair or replacement, considering the risk-benefit ratio, which one would you choose?
So it really depends on the patient. I am still in favor of repair with edge-to-edge in elderly patients who have comorbidities and have frailty, because I know we get them to moderate, they feel better, they go home the next day. I don't have to worry about them in general. If you're going to give a patient a replacement, patient has to be prepared to be in hospital for several days, up to a week, to be, going through more intense modification of their medications. It's more of an investment. But once you make that investment, the payoff is huge because the TR is gone. And assuming TR is the cause of their symptoms, there's no question in my mind the symptom response is greater when you completely eliminate TR. So I don't have the answer that it's replacement for everyone, as some would say. I think there's still going to be a role for both.
Thank you.
Thank you. Augustine?
Yes, thank you very much for this incredible presentation. You showed us a case of transcatheter edge-to-edge repair with a pacemaker lead, and we showed a lot of patients, more and more patients with this kind of lead, which can be a huge problem because of the visualization of the leaflet, both of the coaptation. What is your experience with this kind of patient with a pacemaker lead?
So if the cause of TR is from the lead itself, then edge-to-edge doesn't really work that well because the lead is adherent to the valve leaflet. It's propping it open and, pulling on the leaflets with the clips, I don't think is necessarily the way to go. If they have a bystander lead, it has nothing to do with the TR mechanism, or they have two mechanisms of TR, lead-induced and functional, and you want to pursue edge-to-edge, that's still feasible to treat those patients. But if it's purely from the lead, you could try extracting the lead, which of course has some risk. Our approach in general is to simply do replacement and jail the lead and forget about it. If you do that, you have to have a backup pacing strategy in mind because some of these patients are pacemaker dependent.
Thank you.
Thanks, Neil. Manav?
Thank you, Dr. Pham. That was an excellent overview. My question is about sort of patient selection and communication with kind of our general cardiology and internal medicine colleagues. A lot of these patients, they may have severe TR on an echo that then after they get diuresed, they feel a lot better. And for this reason, we often get referred our patients very late after they've developed significant RV dysfunction. But my question is, you know, after they feel better and their TR is improved on their echo, should we still be, how should we be following these patients in order to catch them before they've kind of gone too far? And what is the kind of sweet spot in your opinion? Because a lot of patients may say, you know, I feel better when I'm on the right kinds of medications and I don't see the need for an invasive procedure.
So, I mean, the fascinating thing about TR is it can be well tolerated for decades. And some patients adapt better than others, and it's something we don't fully understand. You know, on the left side of the spectrum, you have the patient who has asymptomatic severe TR and a dilated RV, and very proactive cardiologists will refer that patient for an intervention. Now, here in Canada, it's not reimbursed. I don't think we have any evidence for intervention in such a patient. This is not surgical mitral repair with 95% chance of success. This is not, we're not at that state. Maybe in the future we will be, but we're not doing prophylactic procedures at this time. I think they have to have symptoms. They have to be on some diuretics. The truth is a combination of diuretics will often lead to improvement in symptoms. The TR may regress to moderate. I don't think there's any strong evidence to pursue intervention in that patient, although we may learn in the future that that's the case. Rhythm control of AFib is very important. So recent onset AFib, cardioversion, rhythm control can be effective. So all of these medical aspects, which are not well standardized, I think are important. You know, one of the concerns I have with the Triluminate trials, because the medical regimen and rhythm control is not standardized, unlike what we had in COAPT, and because the spectrum of symptoms and heart failure burden is so variable, it's a heterogeneous population, it's hard to predict whether the trial will be positive. But I think it will show some benefits is my guess, and it'll probably be positive, at least for heart failure, if my crystal ball is correct.
Yeah, I agree. I think it'd be a pretty, I mean, I think eventually one of these studies, if well done, will show mortality benefit. But my concern is that it's not gonna, you're gonna need probably 2 years at least for the curves to start separating. I mean, if you look at FMR and mitral, you know, you look at the Coab curves up to 1 year, they don't separate at all. They only start separating between 12 and 24 months. And for many of the studies, well, some of the studies, the endpoint's at 1 year only. And I'm not sure 1 year is enough to show mortality benefit in this population. 2 years may not even be enough. It may need to be even longer than that. But, you know, the challenge we've faced with patients, I mean, is that, like you said, patients feel better after you clip them. And the ones who get randomized to medical therapy are really unhappy that they randomized to medical therapy, that, you know, they want to get treated. Because we have the same issue here with reimbursement, I guess, such as you. It's not reimbursed for tricuspid and won't be until one of the randomized studies is positive.
It's true. You know, the other thing that holds this field back is the difficulty of tricuspid imaging. And not everyone is Edwin Ho. So for the average interventional group who does some MitraClip, it can be quite intimidating. And the problem is they do some drive-by tricuspid clip after doing the mitral with the off-label approach. And if they don't get a good result, they may never want to do that procedure again. So it does require a bit of dedication to get over the learning curve. But once you've done that, patient selection is not necessarily all that difficult, and the procedures don't have to be long. But I think that is something which limits edge to edge. And as you know, some of these replacements can now be done in 10 minutes and don't rely on leaflet grasping. It's a lot like TAVI. And there is a certain elegance to the simplicity.
Agree. Nikos and Samina?
Thank you so much for the wonderful talk and review. I have one question. You mentioned that with the tricuspid replacement, there's a risk of pacemaker dependency at 10%. And I was wondering, in your experience, is there any predictors of like heart block and dependency on the pacer before the procedure based on their baseline EKG?
So it's the opposite of TAVI. So TAVI, you have a right bundle, you compress the left bundle, you get complete heart block. For tricuspid, you have a left bundle, you're more likely to compress the right and give them complete heart block. So new right bundle is something that we see after TTVR, but it doesn't always progress to complete heart block. It's completely unexplored question, which we're going to learn a lot more about.
And Neil, what's your pacing strategy after the valve's gone in? If someone needs a pacer, I mean, where do you put the pacer?
Yeah, so we ask our EP colleagues to put in a coronary sinus lead or a leadless pacemaker. If that's not feasible, then we have put leads through the new valve, which is the least favorable, but we ask them to do it echo guided so it's in a commissure.
Okay, great. Nikos, do you have a question?
Yeah, it's also about patient selection, similar to previous panelists about the RV dysfunction. So is there some hemodynamic marker or some echo marker that can guide your decision and say, okay, now we have reached the point of no return. No matter what I do, even if I repair it, the patient is going to do poorly. I'm not going to be able to win him from minor drops. He's not going to be able to make it out of the ICU. And the reason I'm asking is that some of the hemodynamic markers like PAPI or RV stroke volume may be affected by the presence of TR. So do you see like a combination between echo markers and hemodynamic markers can guide this decision?
Yeah, I mean, there's emerging data on this. If there's a discordance between the echo estimated PA pressure and the invasive PA pressure, those patients seem to do the worst. For pulmonary vascular resistance, I think if it's more than 4 or 5 and there's no reversibility, then I would be concerned about doing any valve intervention. But as I said before, post-capillary pulmonary hypertension due to left-sided heart disease, in general, those patients do just fine. As long as you can, control that medically, it's not been a problem. But as far as the end-stage patient, the assessment of RV function remains quite qualitative unless you systematically get MRIs, which are not always easy to get. From the congenital literature, an RVEF less than 45% suggests, a poor prognosis, but I'm sure we've done these procedures in patients that RVEF is 30% and they've done okay. So it's really not just the numbers, it's also the clinical picture and the syndrome of the patient. So the one who has cardiorenal syndrome, low cardiac output, poor RV dysfunction, pulmonary hypertension, cirrhosis, stay away. Even if they walk into your office, don't treat them. Replacement. They're going to be in your hospital for months.
Thank you.
That's great. Neil, thank you so much for the great discussion. I got to say, I was really impressed by our fellows' questions. They were all spot on. We must be doing something right here at Monty. So, thank you to the fellows. You guys were all great. It was every question was superb and on the spot. So thank you. It was a great discussion. Neil, thank you for taking the time, my friend. I'm sorry we won't be seeing each other in Orlando, but hopefully soon in person.
Sounds good, guys. Have a good day.
See you.
Okay. Bye-bye. Take care.